Hello, good day. Today we just wanted to discuss the the five method system. This is not the 5 zone decode system, to be fair, because there's another lecture that talks about the 5 zones of an ECG. But this is going to give you like a flow chart that you can just have in your mind whenever you're seeing any ECG. For many ECGs, you will know straight away that something is off about the ECG, whether it's the way the T waves have gone, or whether it's the way the ST elevation has occurred. You will know that there's something awfully wrong with the ECG. Right. And so, but in some cases, the changes are there, but you can't make it out. Anyway, for any ECG, especially if the ECG looks normal or it looks just too perfect or too good to be true, I try to follow this 5-step system. And what is it? What you want to do is you want to look at RAIC, right? You want to use the RAIC method. And what's the RAIC method? The RAIC method is R, another R, another R. Sorry if I'm not noticing well. Another A. This is supposed to be an A, yes, then I, and then C. This is the entire concept of, of what we mean by the RAIC method. And what are you looking for? Your first R is the rate. The second R is the rhythm. The third thing is it regular? So it's 3 hours for me. Rate, rhythm, is it regular? And what is the rate? When we mean rate, we're talking about, for example, how many small squares do you have between 2 hour intervals divided by, how many small squares do you have, or how many big squares do you have, in between 2 hour intervals. And so there are several methods with which you can check the heart rate on an ECG. Many times it is often automated for you, so you often don't have to do it yourself. But if you have to do it, what you have to do is to say, oh, the number of large boxes between 2 hour intervals. And I have another ECG where I talk about the P wave, the Q wave, the R wave, the S wave, the T wave, the U wave, the J wave. I talk about all the parts of an ECG that makes the rhythm up. So if you're not familiar with it, do send me a message, or if you just want that video, I can send you a link if you send a message. But basically, you're saying how many large boxes are between 2 consecutive hours, and you divide 300 by that number, or how many small boxes are there, and then you divide 1/500 by that number, and then you get the heart rate. And if you know the heart rate is 60 to 100 beats per minute, if you know the rate is there, the next thing you would ask yourself is there a P wave before a QRS? And a P wave before a QRS tells you that most likely that is sinus rhythm. If you're struggling to find the P wave, start asking yourself, am I dealing with an atrial flutter, an SVT? But in most cases, an atrial fibrillation, because that's way more common, isn't it? And what you're trying to find out is, where are my P waves? And is every QRS being followed by a P wave? If you're having the fact that a P wave is being followed by a QRS, a P wave is being followed by a QRS, and suddenly the P disappears, what are you thinking about? You're thinking about a block, right? Is there a kind of block going on here? So it's always good to have a basic knowledge of what you're looking out for, but this 5-step formula is something that you can use to scan any ECG in under 30 seconds to know. So the rate is always most likely done for you. If not, you calculate it quickly. The rhythm is done for you. Well, it's not done for you because you've got to find the P wave. So absolutely not done for you. But in some ECGs, it will tell you a sinus rhythm is present, or, sinus arrhythmia is there. And then you're looking at the regularity. So a lot of people use the paper method, and I've done videos on that as well, where you just mark the paper and then you shift the paper on your ECG strip just to see if it maintains the same distance between 1 hour to R, if it maintains that same distance across your reading strip, and then that can give you an idea of the regularity. But if you wanted to make things easier, especially with checking for ST elevation bits like that, you can get an ECG ruler. It's quite cheap, if I may say so, and and then it also has a barcode. It has annotations for you that you can use to remember what your axis is and other things that you need to check. Now, the next thing after doing your rate, rhythm, and regularity is to move on. You check for your axis. An axis is your QRS in lead 1 positive? Is it positive in AVF as well? And some would check even lead 3 to be sure. So check your axis. And a normal axis means that's fine. Look at lead 1 and AVF. Try and just really focus on that. If there's axis and there's alignment, then you have nothing to worry about. But if there's right axis deviation, left axis deviation, you want to think, and in right axis deviation, we always say right to kiss. In left axis deviation, we say left to leave. And you're asking yourself, is there, especially with right axis deviation, what's going on here? Is there obesity? Is there any respiratory problem? And, you just want to get that out of the way. But I will explain. It may mean something and it may mean nothing, but I will get to why it can mean something and why it can mean nothing when I get to C part of the RAIC. And basically, just so you know, the axis can tell you things about, for example, is there and axis does have deeper meanings. For example, axis, my normal axis between minus 30 to 90 degrees. But if you're not, I mean, well, you can memorize that for exams. But in real life, I like to explain this with, the model of a heart, using an heart model and explaining why the QRS is expected to be positive in lead 1. And now why it's expected to be positive in AVF, if what we are thinking about in terms of left axis deviation, if it is negative in AVF. And so because causes of left axis deviation can be left anterior fascicular block. Is there left ventricular hypertrophy? You'll have other clues as well. Is there a myocardial infarction? Is there a left bundle branch block? And with LAD, the mnemonic I usually use for left axis deviation is ALIVE. That A is anterior fascicular block, L is LVH, I inferior MI, V is ventricular pacing, E is endocardial cushion defects. So basically, that's what your left and your right axis might point you towards a PE, like I mentioned, a lateral MI, a left posterior fascicular block, a right bundle branch block, congenital heart problems. And the mnemonic for right axis deviation is recap. That's R for RVH, or right bundle branch block, E for embolism, that's pulmonary embolism, C for COPD, A for ASD, P for posterior fascicular block, right? And then you want to move. So, but really, you've checked your rate rhythm, you've checked your lead 1, your AVF. Are they positive or are they negative? Or are they trying to kiss? Like the QRS are pointing towards another. Are they left to leave? They're pointing away from one another. And is this the left axis? You're building up a case here. So you're building up a case. You've looked at the rate rhythm. Oh, is there tachycardia going there? Is it a sinus tachycardia? And do you now have a right axis deviation? At this point, you're building up a case. Could this be pulmonary embolism? Could this be obesity? Do I need to pay attention to the next steps? And then so you go to your I, which is your intervals. Your PR intervals should be between 0.1 to 0.20, right? What is the shape of your P wave? Are they bifid? Are they wide? Are they tall? They can tell you a lot about atrial enlargement. What is your QRS interval? Is it normal, 3 small squares? Or is it wide? And, for example, if you're seeing a wide QRS and a left axis deviation, you're looking more closely, aren't you? And you're thinking about left ventricular hypertrophy, right? And for also under intervals, what I like to also mention is, for example, under intervals, I lump it up with Well, you don't need to see it as a lump up really, because under intervals, you want to check your QRS width, right? And you're looking at, is there an LVH? But what I wanted to bring up here was a bundle branch block. So you know that in your left bundle branch block, you have your William Marrow, and in your right bundle branch block, you have your Marrow William. So if a QRS is wide, for instance, let's put it to you, a QRS is wide, right? And you're finding left axis deviation, right? And the rate, say the rate is normal or quite fast, and then the next thing you want to do is to look out then quickly in V1 and in V6. Are you getting, a left ventricular hypertrophy pattern in terms of, the William Marrow? Exactly what is your and what exactly is your R wave doing in V1, your S doing in V6, so you can put the story together now. And that is what I've talked about. Now for me, my C is context. Now 4 and 5 and 3, apologies to those who made this, they didn't follow quite the instruction, but part I, we talked about R is rate, rhythm, regularity, axis, intervals. C is context, and context is king, right? Context is everything. If you've done your rate, rhythm, you've done everything up to this stage, and even if everything is normal, when you get to C, if the context puts you off, then that ECG may look normal on paper, but it may not mean that everything is fine. It may not be normal for that patient. So what you want to do is, and how do you get context? By asking the right questions. So if they give you an ECG to read, you want to know the story. Is this patient, where is this patient? So no matter what ECG I'm being given to read, no matter how normal, I want to know at the end of everything, or, early on, depending on how quickly I read the ECG. If I read it in 30 seconds, then the next minute I'm asking you, how is this patient, or what did they come with, or where are they, right? Because you could have a normal ECG and the patient is dead, or, but obviously the ECG won't be too normal, but you could have a near normal ECG or a normal ECG, and if the patient is not alive or is breathless, or, that could be pulse electrical activity. And I know I painted an extreme scenario, but yes, you could have a normal ECG and the patient is having chest pain, or an ECG that looks normal at first glance, and then you find out that, when you look closely better, or you do serial ECGs, there could be more Q waves. I've seen quite a number of cases like that. So context is king. If you're not able to get enough context, or you've seen something new on that ECG, go into the patient's record, see if you can find a previous ECG that you can compare with. I hope this has been very helpful. Remember, rate, rhythm, regularity, axis, intervals, and context. See you in the next one.